Okay, our next speaker is a privilege for me to introduce Professor Dr. Eva Bezak from University of South Australia. Prof. Bezak is a very famous face in Malaysia. She became our mentor since many years ago. She is a professor in medical radiations and currently the Center Director for Translational Cancer Research in the University of South Australia. She is the current Secretary General for IOMP and the Vice President of ACOMP.
Udah ada pronunciation.
Tadi Kak Wahyu bilang sendiri,
Oh, iya.
Reza.
I'm sorry, there's some background noise just now. Professor Bezak also is the former president of ACP-ACM, as well as the external member of AC4 IUPAP. Prof. Bezak and her group are the national leaders in radiation biology modeling using Monte Carlo algorithms that developed a new microdosimetry measurement technique for detection of alpha particles for use in targeted alpha therapy using the time peaks detector, which was developed in CERN and is one of the most exciting microdosimeters on the market. Prof. Bezak has published definitely more than 160 papers, 280 conference presentations, and co-authored books on medical physics. Prof. Bezak, please.
Thank you, Chai Hong, for your kind introduction, and thank you for your invitation to have me to present at this meeting. I will start sharing my screen.
Yes, thank you.
Let me just make sure that I can share the screen. Share. Okay, are you able to see my screen now?
Yes.
Yes, okay, wonderful. So thank you, everyone. So you will spend exciting 45 minutes with me, where I will be talking about radiation biology modeling. I will cover concepts such as linear quadratic model, tumor control probability, normal tissue control probability. I will talk a bit about the data that we use for these models, and also we'll finish with an example of using BioSuite software that will allow you to do biological comparison of treatment plans. Unfortunately, I have to warn you, there will be a lot of equations, so I will try to make them as simple as possible. Let's see how we go. So you are very all aware that today up to 50% of cancer patients should receive some form of radiation therapy as part of their treatment. A key advantage of radiation oncology is that it is a very effective and non-invasive anti-cancer treatment without any associated mortality risk. And radiation therapy contributes towards 40% of cancer cures, which is comparable to surgery for the fraction of the cost as compared to chemotherapy. However, it is associated with side effects. So really the premise of radiation cell kill in radiation oncology is fine-tuning the balance or the therapeutic ratio between the tumor control probability, which you would like to be 100% because you are trying to eradicate all the cancer cells, while you are minimizing the normal tissue damage or normal tissue control probability of surrounding healthy tissues. And this point here is a useful therapeutic windows where the dose that corresponds to a nice separation within these two curves between the TCP and NTCP is the ideal dose to be prescribed to a patient. So how are these TCP and NTCP curves built? It's not very simple. They are built in each clinic, organization with multiple clinics, or even a country by collecting patient outcomes. These outcomes include cancer-related outcomes, such as survival or progression-free survival, as well as side effects or toxicities. These outcomes then can be correlated to dose distribution in the target volume or cancer, as well as in surrounding healthy tissues or organs at risks. Sometimes the population of data is not enough. So really we should be collecting this data nationally and internationally within the registries. Then you have a team of experts within a clinic that will come up with these correlations between dose volume distributions and your radiobiological tumor control and normal tissue complications probability models. And then they can give you recommendations on prescriptions. Ideally, we don't really care about the tumor. If I could, I would give tumor as high dose as possible, let's say 1,000 grays. But really, that high dose is not achievable because I am limited how much dose I can deliver to the surrounding healthy tissues. But of course, if these curves are being built by collection of data nationally and internationally, this means that these curves are also population averaged and do not necessarily reflect the response of a single patient. The dose volume data, as many of you would know, this dose distribution, let me come back, that I have underneath, can be then represented in terms of dose volume histograms. And in the ideal world, I would like to have 100% dose to the 100% of the volume, so nice square graph, but I would like to have 0 dose delivered to 100% of the volume. So for more normal tissue complications, we want this dose distribution data being as close as possible to the 0 dose and to y-axis. So in radiotherapy, we need individualized prescriptions. Let's have a look at this international clinical RTOG trial for head and neck squamous cell carcinomas. And in this trial, the typical prescription of 70 grays were escalated to 80 grays. Yes, they did achieve increase in tumor control probability from 46% to 61%. So on average, for a population base, you would say, oh, this was a great success. But when you think about it, 46% of patients were already well controlled for their disease with 70 gray dose. So by increasing the dose further, I am potentially only increasing their normal tissue complications. And nearly 40% of patients are still not controlled with 80 grays. So population-based TCP curves are good. However, they will not work for every single patient. So how do we resolve this challenge? We need to run more clinical trials. We need more research and development using in vitro animal models, or we can do further advances using computational and radiobiological modeling that would allow us to fine-tune prescriptions for individual radiation sensitivity and radiation response of an individual patient. So radiobiological models are very useful because they allow us to quantify the biological effects of radiation, and they can provide us with prediction of clinical outcomes, either under known conditions, but also for conditions that were not previously measured. Let's say different fractionation schedules. It will also allow us to optimize radiation therapy treatments, let's say if it's combined with chemotherapy. And it will allow us to identify and evaluate radiation risks. And it's not only for the case of radiation therapy, but even, let's say, for the case of the doses to astronauts during the long duration space flights. The types of radiobiological models could be biological, using cell lines or animal models, or with the use of registries, I can use population data. I can use mathematical or analytical models, such as linear quadratic model, or to lesion kinetic model, or I can go fully sophisticated and use computational or stochastic models such as GN4DNA, RITREX, and similar. So let's cover some of these models. And really, the bulk of the radiation oncology prescription is based on the linear quadratic model that has been proposed by Jack Fowler in 1972. And this model is used to predict the survival probability of tumor that consists of a number of clonogens with a given alpha and beta values for a given dose D. And this is a graph of the surviving fractions, where you can see that the low LET radiation or sparsely ionizing radiation, as discussed in the previous lecture, has a slowly declining survival curve as a function of radiation dose here on the y-axis, compared to the densely ionizing radiation such as alpha particles or neutrons that has a rapidly declining survival curve at smaller doses of delivered dose. This one becomes nearly linear. Please notice that this is a logarithmic scale on the y-axis, and it's being dominated by the linear component of this linear quadratic model. Because there is a dependence of the survival on the linear function of the dose and quadratic function of the dose, we have the name linear quadratic model. It can be used to predict alternate fractionation schedules. It can be used to prescribe doses. The advantages are that it's a simple mathematical formulations. Interestingly, it gives relatively accurate predictions, but the disadvantages is that we do not often know what the alpha beta values are. They are valid for a very strict set of conditions. It is a macroscopic model. It really doesn't tell me anything what's happening on the cellular level within the DNA. The alpha beta ratios is defining the curviness of this surviving fraction slope, and it really quantifies the fractionation sensitivity of the tissues. The tumors and early responding normal tissues, such as the bone marrow, have alpha beta ratios generally around the value of 10 grays, and that means that these tissues are less sensitive to a change in fractionation, total treatment time, and the dose are most important. Late responding tissues, which are most of the normal tissues, have alpha beta ratios within 1 to 3 grays, and they are most sensitive to a change in dose fractionation. Therefore, hypofractionation, where you are irradiating tissue with the smaller number of fractions with the larger dose per fractions, may be beneficial. Professor Curtis in 1986 proposed the potentially lethal model, which is actually a microscopic model because it predicts cell survival based on microscopic damages or double strand breaks instead of just macroscopic delivered absorbed dose. It is more sophisticated because it also accounts for dose rate, radiation type, and cellular characteristics. And under certain conditions, it can reduce to your familiar linear quadratic model. So it really represents more accurately the cellular radiation biology, but is mathematically more complicated. I don't need you to understand this model. I will show a graph how to explain it, and you can read about it in literature. But this model is looking at the number of potentially lethal damages to the DNA as a function of dose rate during the irradiation time. And then the surviving fraction of the tumor cell is a function of dose rate, and the treatment that is available for repair after the exposure time before you hit the tumor with another dose of radiation. These two parameters, EPL and eta 2PL, are cell type dependent. So this is really what it does. Initially, you will irradiate all viable cells that don't have any lesions inside the tumors. And the radiation can either cause complex double-strand breaks that will result in lethal lesions and therefore cell death. This is really corresponding to your parameter alpha in the linear quadratic model. Or it can create potentially lethal damages like simple double-strand breaks or single-strand breaks of the DNA that are repairable lesions. These can undergo correct repair, and these cells will again enter the cell cycle and can contribute to tumor growth. Or they can be misrepaired, and because they are misrepaired, they can result in the cell death. So now that we have defined the surviving fraction of the tumor, we can define the tumor control probability. That is that first S-shaped curve that determines the success of the treatment. So the tumor control probability is yet another exponential function where it is equal to e to the minus n times surviving fraction, where n is the number of tumor clonogens or clonogenic cancer stem cells, where we can then substitute the linear quadratic model for the surviving fraction. So it's really a double exponential. In this case, because we are dealing with fractionated radiotherapy, small d is dose per fraction, which in the standard radiation therapy, this is 2 grays per fraction, and n is the number of the treatment fraction. The alpha beta data is generally determined in vitro. And when you look at this model and you plug the numbers in, strictly speaking or mathematically speaking, one single cancer cell surviving radiation therapy will reduce tumor treatment control to 37%. As a result, the objective of any radiation therapy is to eradicate all cancer cells. In real life, this is not exactly true because we have other effects like a response of the immune system or bystanders effects that can actually kill or eradicate any remnant cancer cells. So there are lots of problems though with these models because in real patients, the number of clonogens can have varying sensitivities inside a single tumor. They don't have the same alpha beta. You will have different sensitivities between patients. So therefore, you will be dealing with a range of alpha beta values within a patient and between patients. Alpha beta values are also dependent on the cell cycle. And cell kill, as we heard in the previous lecture, depends on the oxygen content inside the cells, and hypoxic cells are more radioresistant. Yet we are expecting that all clonogens must be eradicated. So I very quickly show you a proper equation for tumor control probability calculations that are really the individual populations for an individual averaged over population, where you then having not a single alpha beta ratios, but multiple alpha beta ratios that expresses variation of TCP within a patient and within the population. Andrew Nemirko and Michael Goiten are really the radiological gods when it comes to looking at the tumor control probabilities for population of patients. So I highly recommend to read that article. So we have discussed the first S-shaped curve. Let's now talk about the normal tissue complications probability. The modern knowledge of normal tissue tolerance is based on a seminal publication by Imami, published in 1991, And this is a must for everyone who works in medical physics and radiation biology and radiation oncology. The values of tolerances were based upon uniform irradiation of 28 critical normal tissue structures, and complication rates reported in clinical literature were also compiled. In the same year, Berman published tolerance dose data based on a phenomenological NTCP models proposed by Lyman in 1985. And I will show again a couple of equations and discuss the data that is being used in that model. So this model is once again an exponential function where we are integrating over a parameter t square, where t represents the dose to the organ relative to D50 dose. And D50, sometimes later in my lecture, I will be referring to is as the TD50, is the dose that will produce 50% probability of complications. So where the whole organ is exposed to the D50 dose, 50% of those patients will have that negative side effect of radiation. Let's say it's radiation pneumonitis. M represents the slopeness of the dose response, how fast the slope is of the dose response curve. What you don't see here is the dependence on the volume. So this is a very simple expression that assume that the normal structure received uniform dose. This is usually not the case because the normal tissue lie within the dose gradient and penumbra of the dose. So the more generic expression for the parameter T is where we use the general equivalent uniform dose, and I'm not explaining this term within this lecture, that actually depends on the volume and dose distribution within the normal tissue, meaning that some parts of the normal tissue, such as lung, may be receiving larger doses, and some parts of the normal tissues, again, such as lung, will be receiving lower doses. To make the matter even more complicated, not all tissues are equal. And one of the questions we could ask is, what about the organ architecture and its effect on the response to irradiation? Very briefly, maybe many of you are already familiar, we by large divide normal tissues in parallel structures and serial structures. This is once again a simplification, and some organ can be 50-50% of each. In parallel structures, if some organ subvolumes are inactivated due to irradiation, the organ can still perform its tasks. Example is liver, lung, kidney. So even if I, after irradiation, knock off parts of the lung, the patient can still breathe. But in serial structures, if any one subvolume is inactivated due to irradiation, the function of the whole organ is impaired. Example is a spinal cord. So if I inactivate a volume of the spinal cord, then the patient movements will be affected. So the relative seriality model has a different mathematical expression, but once again, I want to show you that we have again exponential dependence on the dose delivered to the organ relative to the D50 dose. Once again, this is the dose that produces 50% chance of complication. We summarize this over all individual subvolumes receiving different dose DI, but I now have a different parameter S here, which varies from 0 to 1, and this parameter would vary depending on whether the organ is a serial organ or the parallel organ. So I will summarize once again. In Lyman or Lyman-Kucher-Berman model, TD50 is the dose that leads to the 50% complication probability. Slope of the structure, M, determines the steepness of the dose volume curve, and the parameter N is the volume of the structure determining the effective volume dependence in the model. In the relative seriality model, it is the gamma parameter that represents the steepness of the dose response curve for the structures. So if I change TD50, I am also changing the slope of the dose response curve. If I am changing M, I am also changing the slope of the dose response curve. If the volume of the structure N or S is 0, organ has a series structure with limited to no volume dependence. But if N or S is 1, organ has a parallel structure and will have a strong volume dependence. But as you can see, I need to know what the TD50 is, what M is, N is, gamma is, or S is. So the big question, million-dollar question is, where do I get all this data to fit within these models? And this is basically where Imami and Berman-Kucher data papers have provided to us. So in this case, I'm just showing one of the tables. I have a critical structure, organ at risk. I have the reference volume, which I'm using the whole volume to be irradiated as the reference volume. I have the parameters N, TD50, but the TD50 depends on the endpoint. So for example, for bladder, I am looking for a constricture or volume loss in the bladder. In colon, I'm looking at the obstruction or ulceration of the colon. In lung, my endpoint is pneumonitis. If I am looking at the different side effects, these endpoints will be different, and therefore these parameters will be different as well. And this is really the big difficulty of radiobiological modeling. So really the model parameters are the weak point of the model. Going back to the Imami papers, yes, the committees of experts reviewed the known data and provided the guidelines, but look at the year 1991. At that time, we have comparatively poor ability to deliver precisely those, and we didn't have any modern technique like image-guided radiotherapy or intensity modulated radiotherapy. We had a worse ability to measure the dose actually delivered. Some data were estimated based upon the best guess principles. So quickly rewind to the current times. We have moved from 2-dimensional to 3-dimensional treatment planning. We have state-of-the-art treatment techniques. We have higher energy beams produced by our linear accelerators. We have much better calibration protocols and ability to measure the dose. We now use increasingly combined hemoradiotherapy. And we have many more data nationally and internationally that report on tissue tolerance. As a result, a special expert group known as Quantec, which is an abbreviation for Quantitative Analysis of Normal Tissue Effects in the Clinic, has been founded. It's a large committee of experts convened by the American Association of Physicists in Medicine and Astro, and they updated guidelines that were published in your red journal in the supplement, and it contains 16 organ-specific papers. So Quantec was formed to provide critical overview of the current state of the knowledge, produce practical guidelines, and identified future research avenues. This is the reference, And again, it's a must for everyone to read and have in your data collection of papers. These are the organ-specific papers, starting from brain to optical nerve, brain chiasm, going through head and neck organ, lung, heart, esophagus, liver, finishing with rectum, penile bulb, and bladder. And each section is talking about clinical significance, endpoints, challenges in defining the volumes, conducts revision of those volume data, looks at factors that are affecting the risk, and then provides some mathematical biological modeling. I will show you now a case of radiation dose volume effects in the lung, and will take you through two graphs. The top graph is fairly easy to understand. In this graph, we have probability, for example, in case that you are treating lung cancer in that patient, the typical side effect for that patient would be development of the radiation pneumonitis. And the group has put together lots of clinical trials. And what you are looking at is the mean lung dose in grays and the probability of pneumonitis. And what we see that most of that international data is really falling on the same graph. And the dashed curve here is the line of best fit. So it's telling me that, for example, if the mean lung dose is 20 grays, the probability that that patient will develop the radiation pneumonitis is 20%. The second graph is more related to how we prescribe. You know that we prescribe the dose to the tumor, but the clinicians will also prescribe dose constraint. We have an interesting unit here. This is called, for example, V20. And it describes the volume of the lung receiving 20 gray dose. So the clinician will define a constraint that will limit the lung volume in cubic centimeters that can be exposed to 20 grays. Here we have the incidence of radiation pneumonitis versus Vx in percentage. So now the individual studies are split up, whether they used V40 constraint, V30 constraint, V20 constraint, or even V13 or V5 constraint. So I'm talking here V40, volume of those that receive 40 grays. And what do you see? If the lung receives 40 grays, the incidence of pneumonitis increases. And if that volume that receives 40 grays increases, this incidence of pneumonitis goes nearly vertically out. So there is a strong dose volume dependence. However, if I keep the dose constraint at 13 grays, then the volume that as it's being increased, but being increased to 13 grays, the incidence of radiation pneumonitis is rising only very slowly. So this type of graph is a better breakdown of this generic graph to allow doctors in clinic to prescribe the dose volume constraints for their patients. So lessons from Quantec, we are not only looking at the spatial and anatomical distribution of data, we are looking at the dose volume histogram data, and we are trying to use that dose volume histogram data either to calculate the global mean dose or to calculate the single constraints such as V20, which is the volume that is permitted to be exposed to 20 grays. But we also can use this dose volume data to compute the normal tissue complications probability models that I have shown you previously. This is also allowing me potentially to have alternative prescription approach. I do not have to necessarily prescribe the dose to the tumor, but I can selectively dose escalate patients to any tumor dose up to some threshold for normal tissue complications. So I can give as much dose to the tumor for as long that I am not exceeding the threshold doses for normal tissue complications. The disadvantage of this could be that for bigger tumors, you will only receive lower tumor doses. So ideally, where do I see the biological treatment plan optimization to go? And I have borrowed this from my collaborator and colleague, Alan Nahum. They estimate with his PhD student, Uzan, 5 stages in development of biological-based treatment. Level 1 is using individualized prescription on ISO equivalent NTCP basis. On level 2, we are looking at individualized dose prescription, but also individualized fractionation on an isotoxic basis, that each patient will have the same amount of normal tissue complications probabilities. On level 3, we should actually use the DVH data and calculate NTCP and TCP models in the inverse planning algorithms. On level 4, we should be including more patient-specific information from functional imaging, such as hypoxia or tumor proliferation in the treatment planning. And on level 5, we should be even including more individual patient biology, such as genomics, added to the above. So I think by large, many departments are only on level 1 and level 2. I'm hoping that we are moving to level 3. And if the rise of the artificial intelligence and functional imaging, we can move to level 4 and level 5. Let me give you a brief example on level 3. So I will be talking about the practical application of the BioSuite software that was developed by Alan Nahum and Julian Uzan. So it is a software that computes normal tissue complication probability and tumor complication probability using various radiobiological models, and can suggest radiobiological optimal prescription doses and fractionation scheme with limited toxicity. It is a shareware that is downloadable, and it allows you for customization of fractionation and prescription dose. I will use a clinical example of a 5-year-old female patient with a brain tumor known as medulloblastoma, and we performed 2 treatment plans, one with photons, intensity modulated photon radiotherapy, and one with protons using intensity modulated proton radiotherapy. The organs and risks, for example, are brainstem, cochlea in the ear, optical structures, and pituitary gland. So in our work, what we have done, we have obtained cranial pediatric data set, which we imported into the treatment planning system. We created the 2 treatment delivery models, looking at the dose distribution models, and we have exported these dose volume histograms to the BioSuite software. And in the BioSuite software, we have calculated the normal tissue complication probability for further analysis. So I have removed the whole distribution from these images to make it a bit easier to look at. Here I have my critical structure, and in this case, the critical structure is sitting next to the brain stem. And the endpoint in the brain stem is necrosis. Now I have the proton therapy on the left and photon therapy on the right, and I want to see what is the risk of brainstem necrosis between these 2 treatment plans. So from any treatment planning system, whether it's Pinnacle, Eclipse, Research, you can export your dose volume histograms as differential dose volume histograms, and you can export them either as text files or you can bring them into the Excel spreadsheets. This is really what the BioSuite treatment software, your graphical user interface looks like. You can select a endpoint of interest. For example, I can look at the radiation pneumonitis, or I can look at the complications of the esophagus. I can select the model. For example, I want to use Lyman-Kutcher model, and then I can enter these parameters: slope, TD50, volume effect, and alpha beta ratio. I can then play with these individual models and have a look how it affects the calculated normal tissue complication probability. So when you are looking at TD50, I am changing individual radiosensitivity based on gender, or maybe that patient also has a chemotherapy delivered to them, which make them more sensitive to additional delivered radiation dose. I can model alpha beta ratios looking at intrinsic cellular radiosensitivity of that organ. I can look at the steepness of the dose response curve. I can play with the volume effect depending whether I'm dealing with the esophagus, which is a serial organ, or lung, which is a parallel organ. And I can also select the relative seriality model, and I can play with the gamma parameters, but I can use the literature reported data, such as those from the Quantec model. So here are some of the examples. We looked at the brainstem. Our endpoint is necrosis. And these are the parameters that we have found in literature, and these are the ranges of the data. We put it into the software, and the software will then calculate the results for us. You can import your DVHs. You can also give the dose prescription, how many fractions the patient has, what is the total dose, how many fractions per day, and how many fractions per week. And we used Lyman-Kutcher Berman model. And the NTCP results were calculated that proton therapy will give you a risk of 0.2% of brainstem necrosis versus roughly 2% of brainstem necrosis when you are using the IMRT, intensity modulated photon radiotherapy. And the software will also recreate from your data the differential dose volume histograms. So this is the end. My final remarks. Radiobiology absolutely impacts on treatment planning, and its impact in our clinical practice will be increasing. The delivered radiation dose is only start of the journey and part of the journey. New radiobiological data needs to be collected through clinical trials and must be implemented into the treatment planning systems and other model-based calculations. And hopefully more individualization will be possible that will consider patient-specific parameters. Thank you very much for your attention.